Dear ESTS members and webinar attendees, my name is Lieven de Pipperen, your ESTS webinar coordinator and moderator for today. This is the third webinar of the 2019-2020 series, and today will be about enhanced recovery after esophageal cancer surgery. Therefore, I'm very proud to introduce you to Professor Donald Lowe as a guest speaker. Dr. Lowe is head of the section of General Thoracic Surgery and Surgical Oncology at Virginia Mason Medical Center, and he's assistant professor of surgery at the University of Washington School of Medicine. He's a director of the Esophageal Complications Consensus Group with landmark papers on classification of complications in esophageal surgery, and he's also the managing director of the International ESOData dataset, including data of a lot of expert esophageal cancer centers worldwide, with data being used for the next TNM classification of esophageal cancer. Because of his special interest in and many publications on enhanced recovery after esophageal surgery, he is the man who can tell you a lot about this topic. Dr. Lowe, please, the stage is yours. So, if you go to actions, enable screen sharing.
All right.
Then your screen is up. And then the complete screen, you click on that. And share. Yeah, perfect. And then you go to your presentation.
Okay. Let's see. All right.
Perfect. We can see you, we can hear you, and we see your slides.
Well, you seem to have a bit of an echo.
Yeah, that's true. What can we do about that?
I don't know.
Is that better?
Well,
no. Is there a computer close by?
Yeah, I mean, yes.
Are there two computers close to each other?
No. No, there's only one.
Okay. And the volume of your own speakers, can you lower them a little bit?
I can try. Yeah. Is that better?
That's much better. Perfect.
Can you hear me now?
I can hear you, yeah.
Okay, should I start?
Yeah, perfect.
Okay, if you can hear me, first of all, thank you for this opportunity. It's always a delight to address my European thoracic colleagues. You've asked me to address a topic close to my heart, which is ERAS guidelines in esophageal surgery, but specifically addressing issues associated with esophageal resection. I'm going to start by highlighting where we are in the evolution of esophageal surgery internationally. If we simply go back to 2005, which is not all that long ago, surgery dominated the field at virtually every stage of the presentation of both squamous and adenocarcinoma, including people, including myself, operating on high-grade dysplasia and T1A disease. If we move less than 15 years forward, you can see that surgery has been relegated to an area of addressing regional operations. There is some debate as to how T2N0 should be dealt with, but with respect to regional cancer, surgery continues along with adjuvant therapy to be the major player. However, is even this position secure? Well, if you look at the aspect of what's going on in Europe regarding the SONO trial and the ESOSTRATE trial, they are examining the opportunity with neoadjuvant chemoradiotherapy to initiate a surgery as needed approach to even regional cancers, and introducing this as a potential for becoming standard of care long term. If we were to ask ourselves why we've arrived at this particular juncture, it's because the aspects of the reputation of esophagectomy has historically not been very good. And in the long run, it has been associated with what many people consider to be an unacceptable level of mortality and morbidity. During this same evolution, most of the time, not all, but most of the time, surgeons have been concentrating on their operations, which is completely understandable. We've had this impression, if we can just do the perfect operation, then everything else will follow along. In fact, doing good surgery remains at the absolute heart of what we should be doing and how we should be looking at our own contribution. But quite frankly, the comprehensive aspect of recovery after esophagectomy must take in many other issues. If you don't believe me regarding this concentration, here is an EATS program from not too long ago asking myself, Mark Oranger, Tom Rice, Nasser Al-Turki, and Jim Lukatich to highlight why individual operations were considered better than others. I think I disappointed the EATS group because I highlighted that I thought the Ivor Lewis operation was a very good procedure, but quite frankly, I did all the various operations in this particular group here. Each one had its appropriate situation, but really in the long run, it had to be associated with also a comprehensive aspect of recovery to make sure that our outcomes remained as good as they can be. During this same period, however, there's been another aspect of an evolution which is equally important when it comes to outcomes after major oncologic surgery. These are all examples of publications over the last 10 years looking at various aspects of standardized clinical pathways, ERAS programs, and fast-track programs, looking to make the aspects of the total recovery of our patients more straightforward. Most of you are completely aware of ERAS programs after surgery. They have issues that involve pre-admission, preoperative, intraoperative, and postoperative aspects of recovery, all of which, when applied, can improve overall outcomes. The ERAS guidelines began with colorectal surgery and quickly spread into gynecologic, bariatric, and pancreatic surgery. The guidelines specific to esophagectomy were written and published in February of 2019. They were the first guidelines that addressed the increased complexity of a thoracic in addition to an abdominal operation. It had the same type of introduction with respect to non-specific components that were inherent to most previous ERAS pathways, but also had procedure-specific components that had to expand significantly with respect to preoperative nutritional intervention and the role of multidisciplinary tumor board. Much more specific, however, was the increased need to have a much more comprehensive approach to operative components, especially with respect to the management of NG tubes, chest drains, and anesthesia management in an operation that involved thoracic as well as abdominal intervention. Do ERAS programs work when it comes to esophageal resection? This is actually unpublished data from our institution that we have just put together, doing a comprehensive meta-analysis of all the publications looking at ERAS and looking at its effect on outcome. What we have found in this, I think, still developing literature is even at this early stage, the introduction of ERAS programs in individual institutions has significantly improved length of stay and impacted pulmonary complications at a statistically significant level. At this point, we have not seen differences in morbidity, mortality, and anastomotic leak, but this literature is still developing at this time. Now, if you were to ask, why did the ERAS Society approach me to write the ERAS guidelines for esophageal resection? I suspect it had to do with the fact that at Virginia Mason in Seattle, we have been using a platform called Standardized Clinical Pathways since the early 1990s to direct the entire pre and after care of all the patients undergoing esophageal resections. This is our initial publication in 2007, highlighting that standardized clinical pathways is not just about mortality anymore. And this is a follow-up publication in 2014, highlighting how significant we could impact the outcomes of esophagectomy patients utilizing these standardized approaches, which in fact had almost all of the criteria now applied in ERAS pathways. If you look at the 600 patients that were involved in the publication of the 2014 paper, you can see that there was a significant complexity, or an increasing complexity, to the patients that we were operating on. Age was increasing, BMI was increasing, comorbidity scores were all increasing, including the incidence of diabetes, higher stage disease, and our application of neoadjuvant chemoradiation. During this same period, however, if you looked at the aspect of how these pathways affected our outcomes at Virginia Mason, you can see that our operative blood loss was decreasing significantly during this period. Our utilization of intraoperative fluids dramatically decreased. The way we use the ICU and our hospital stay gravitated toward improvement. And I think most importantly, over an extended period of time, we demonstrated that these operations could be done with extremely low mortality. This is the current pathway that we use at Virginia Mason. It has probably been modified at least 10 times over the past 20 years. It starts at initial contact and goes to the time that we would expect the patient to be currently discharged. Where we're going to concentrate today, though, is on this line here, the critical measurable goals, because those are the issues that are the mainstay of ERAS pathways, and they're going to be the issues that can affect your results in the short term, depending how you introduce pathways and ERAS in your own institution. Here are the measurable outcomes that we look at routinely in my institution. Before I go any further, however, I'm going to take a moment to highlight something that I'll come back to at the end. In anyone using ERAS pathways or clinical pathways in their institution, the introduction is the first step, but not the last. ERAS will not be completely successful if it is not routinely associated with audit of the pathway goals and critical measurable outcomes. And I'm going to try to highlight how important that is, utilizing some specific examples from our own pathway. So can we go over all this in half an hour? The answer is no. So we're going to actually focus on 5 areas which I think I can give you an idea as to how they can affect your outcomes over time. And let's start with early mobilization. What is our current protocol at Virginia Mason for mobilizing our patients immediately following esophageal resection? Our current goal is to have the patient up in a chair 4 to 6 hours after they leave the operating room, to be walking in the hall within 12 hours post-op. That is the patient walking with assistance in the hall within 12 hours of finishing the operation. We target 6 to 8 walks of greater than 200 feet on post-operative day number 2, and we look for the patient to be independently mobile by day 4. This is a picture, and this gentleman has given me permission to utilize this. These are not employees of my institution. This is the head of the ICU at the major cancer hospital in Liverpool, and this is the head ICU sister. This is a gentleman who just finished an open Ivor Lewis operation 3 hours beforehand. He's in our step-down unit. You can see he's 75. He's not on oxygen. He's using not really a very complex mobility apparatus, but he is up and moving. And these people are visiting us to see if what we had been advocating in our papers were actually true, and they found out that in fact they were. With respect to audit, we audited our ability to mobilize people as early as 2009. We found at that point that we were able to mobilize our patients on postoperative day 1 in about 50% of cases. When we reapplied ourselves to achieving pathway goals and changed them, we then did a re-audit between 2009 and 2012, demonstrating that at that point, we were mobilizing people according to our pathway in 72% on the day of surgery and 92% on postoperative day 1, which is a significant improvement over our previous assessment. Discharge targets are something that are an important aspect of virtually everything we do in surgery. And if you look at the background of both ERAS and standardized clinical pathways, we are understandably setting increasingly aggressive discharge targets for our patients, especially with respect to esophageal resection. If you look at esophagectomy data from NISQIP, the STS database, and the National Inpatient Sample in 2016 and 2017, the median length of stay in the United States is about 10 to 12 days during that period. We did an audit of our discharge goal situation in 2012 to 2013. Our current discharge target at that time was 7 to 8 days, and as you can see, we were achieving that target in most of our patients. But we also demonstrated that there was a group that was capable of exceeding even our quite aggressive discharge targets at the time, and we decided to study this group. We looked at the 137 consecutive patients that we operated on in that particular time period. We looked at our targeted recovery group of 7 to 8 days, our accelerated recovery group of 5 to 6 days, and our delayed recovery group at greater than 8 days. We found that the accelerated group, that's the 5 to 6 day group, was increasing over time as our adherence to our pathway goals and our flexibility within our ERAS goals were improving. To make sure we weren't gaming the system with this particular group, though, we examined those 3 different study groups and were encouraged to see that there was no difference in age, no difference in comorbidity status, there was no difference in the type of neoadjuvant chemoradiation they'd received. The mortality rate remained at 1% or lower in all groups, but I think most importantly, there was no difference in readmission rates and no difference in patient satisfaction rates, indicating that these patients who were going home earlier were having comparable results to the group that was going home in a targeted fashion or were in fact delayed. I'm not going to surprise you when I tell you that if you look at the cost benefit of being efficient in discharging your patient, there are significant in cost improvements. Surprising to us, however, is in this accelerated group, even when they required readmission, the readmission cost less than the other 2 groups themselves. So I think this demonstrates that there is a group of patients that we are all managing who are capable of recovering in a very straightforward way, and these patients should be the target of our current ERAS pathway, and this particular publication was released in Annals of Thoracic Surgery in 2016. Perioperative pain. Well, there's hardly an issue that is discussed with more fervor when it comes to the aspects of dealing with complex oncologic operations, and esophagectomy has historically been no different. This is a publication from 2017 from Utrecht, examining the utility of epidural catheters in post-esophagectomy pain and demonstrating quite clearly that there's a technical failure rate of between 17 and 22%. When we did our own audit the year or 2 before, we found that we at VM, our defect rate with epidurals was slightly less, but still significant at about 15%. At that point, we initiated a program of doing an epiduralgram in our operating room. Our hospital legislates an on-table chest X-ray and abdominal film to ensure that there's no retained foreign bodies. So we used this same film to inject our epidural catheters. And we found that these injections could impact the aspects of how we dealt with our epidurals in the immediate postoperative period 40% of the time. We also demonstrated that this could be done with no adverse events. To give you just an example of how valuable this type of assessment can be within a pathway, this is a gentleman who started a left thoracoabdominal operation with an anastomosis in the neck at 8:10 in the morning. We finished the operation at 1:15 in the at 12:50 in the afternoon. This is a patient who still has his double lumen tube in place, and we did the epidural before he was the epiduralgram before he was extubated at 12:03. You can see that the epidural is clearly in the perispinal space and not in the epidural space. This epidural was removed. The patient was taken to the recovery room, and as soon as the patient was conscious, another epidural was placed immediately and another epiduralgram done that shows the epidural is in a perfect location, and that particular interaction took 53 minutes. So we went from this, in which we had a non-functioning epidural, to a replaced epidural in a very short period of time, which naturally improves the efficiency of recovery. This particular issue has also been published in Annals of Thoracic Surgery this year. Hemodynamic protocols. I'm going to take a moment on this because I think it is one of the things that historically has been left out of many of the aspects of how we design our post-operative recovery. Surgeons have spent their entire life debating the aspects of how this particular entity should be constructed, how it should be handled, how wide it should be done, what should we do to the pylorus, how should we manage immediately post-operatively. The bottom line is that a healthy conduit and an appropriate anastomosis will see you through almost any issue. But the other side of the aspect is that how we are using standardized clinical pathways in ERAS does involve conservative approach to operative fluids. It involves regional anesthesia. We avoid perioperative transfusion, and we mobilize patients immediately. All of these issues can improve overall outcome, but in fact, they can all potentially cause immediate post-operative hypotension. If you look at the literature that has specifically addressed how blood flow and blood pressure affects perfusion at the tip of the conduit, the things that become quickly clear is, number one, a mean arterial pressure between 70 and 90 is considered optimal. Bolusing epidurals will routinely impact the blood flow to the tip of the conduit, and the utilization, the judicious utilization of certain types of pressure agents, in this case phenylephrine, can help maintain blood pressure and can maintain blood flow to the tip of the conduit. So what have we not typically done? We've not typically standardized our hemodynamic management in the immediate postoperative period. In fact, many centers throughout the world turn our patients over to ICU personnel, sometimes anesthesiologists, who look at blood pressure as an aspect of cerebral and cardiac perfusion, but have absolutely no comprehension of the importance of blood flow to our new conduit. This is our standardized program, which is now embedded in our order sets. It has to do with how we use fluids and our epidurals. It maintains a mean arterial pressure above 70. If the pressure is not maintained in this area, it gives a stepwise approach to using fluid, checking hematocrit, using norepinephrine, decreasing epidural utilization, more fluid, and then a staff review. This does not take the aspect of thinking out of the post-operative scenario. It does provide a framework, though, to people who are managing these people to ensure they address things in an appropriate way. Most importantly, we do not use epidural boluses for pain after surgery, because this will simply induce hypotension that will then require a response. And we've just published this particular protocol in the literature as well. I'm going to finish up with respect to the aspects of the way we use nutritional protocols. And in this particular case, we're going to talk about some dietary goals and also the methodology in which we use contrast studies to adhere to our pathway goals and our ERAS pathways. Unfortunately, I'm going to tell you that the normal esophagectomy patient in my practice in the United States now looks like this. This is obviously an obese individual, but that does not mean that this particular individual is not malnourished. We typically utilize 14 French feeding jejunostomies, which we routinely place at the time of resection, although more and more we have been placing these jejunostomies prior to neoadjuvant therapy when patients have been identified at risk. We start our enteric nutritional protocols on postoperative day 1. So people are utilizing these feeding tubes on the day after surgery, and we achieve that in 94%. We also have a issue regarding our protocol in which we restart all baseline medications through their feeding tube on postoperative day 2, which we're achieving at 88%. So this is all of their antipsychotropic drugs, their blood pressure medication, their thyroid medication, is all restarted virtually immediately after surgery. This is a very interesting component analysis done by Imperial College, looking at the effect of enhanced recovery programs, specifically and their effect on length of stay. Not surprisingly, early mobilization, early removal of catheters, early oral intake, enteric diet with feeding jejunostomy, and epidural removal all impact length of stay. But surprising to many, but not surprising to us, is this gastrographin study at less than 5 days, although we would say less than 2 to 3 days. We use an immediate postoperative gastrographin study to assess gastric emptying in the second or third day after a patient's recovery. We do look at the anastomosis, but this is really to facilitate the timing of the nasogastric tube removal, which we currently have targeted at day 2 or 3. This is what we're looking for on our immediate postoperative x-ray. We're looking for an immediate and low threshold for gastric conduit emptying. You can see in this particular study, there's virtually no air fluid level, but virtually immediate conduit emptying. And I will say that at Virginia Mason, we typically do not do any interaction with the pylorus if it's found to be non-stenotic at the time of surgery. Equally important with respect to being able to see that type of result is to have a plan within your pathway if you find that you have delayed gastric emptying, which does not allow you to proceed with NG tube removal. We have now looked. Hello. Yes.
In the meantime, I will ask the audience to fill in the poll with
I'm
extra questions from Professor Lowe.
Thank you so much for calling.
So you can already look to them in the polls. So we have 5 questions from Dr. Lowe there.
All right. Shall I just finish up?
Yep.
We have just looked between 2018 and 2019 at 50 consecutive esophagectomies with our current ERAS target of upper GI study and removal on day 2 or 3. We found we met our target at 86%, and we were able to initiate oral intake in 96% of patients within 24 hours of the upper GI study. 4 patients demonstrated radiologic delayed conduit emptying. These patients underwent 1 day of prokinetic agents. If they did not then empty after that, they underwent endoscopy done by us, in which we dilated the pylorus and injected Botox and removed the NG tubes at that time. Interestingly, utilizing this protocol, the overall median length of stay in all of our patients was 7.5 days, although there was an appropriate range of patients. The other aspect about nutritional protocols is we personally do not think it's important that patients eat solid food in the first 2 weeks after their esophageal resection. This is what's given to the patient and the family when they come to our clinic. The first 2 days after their surgery, they're on clear fluid, and then for the next 2 weeks, they stay on a puree diet, which is much easier to swallow. Even this is given in a limited format. I told you that this is our current comprehensive standardized clinical pathway, which encompasses now all the aspects which is in the ERAS pathway. Equally important are these type of protocols, which are given to our patients, and this is actually posted in the patient's room, so they have an expectation of what's going to happen with respect to their recovery every day. This is the information that is given to our residents and fellows. These are outstanding people, but they rotate in and out of our lives, and they must know what their expectations are. I think most importantly, however, this was published by us and our anesthesia colleagues in 2015, and this is a standardized approach for anesthesia in the esophagectomy pathway. And this covers all aspects of pre-anesthesia, induction room, operating room setup, intraoperative management, specific complications, post-operative, and pain management. And once again, this does not take the thinking out of it, but it does give a standardized format for proceeding. You might ask, well, this is all fine, but is it only applicable at my institution? Well, these are the groups that have visited us over the past 10 years to look at our pathway. Sean Preston from the University of Surrey came about 8 or 9 years ago. He took our pathway back to Guildford and University of Surrey, and he introduced an adapted component of our pathway at his institution over the next year. He then published his results in British Journal of Surgery, showing that prior to the initiation of the pathway, in the year prior, they mobilized their patient on day 1 in about 8.3% of cases. They had 67% complications. Their ICU stay was 4 days, and their hospital stay was 17 days. 1 year after the initiation of the pathway, they were mobilizing their patients 100% of the time on day 1. Their complication rate had dropped to 25%. Their ICU stay had gone from 4 to 3, but much more impressively, their hospital stay had gone from 17 to 7 days. So these type of issues can be initiated in any hospital as long as you have your whole multidisciplinary team involved. And this is the groups that have joined us, and you can see that these are not made up just of surgeons. They're made up of nurses, operating room techs, physical therapy, dietitian, all the people who you will need to partner with to make sure these pathways are successful. You also might say, do these pathways impact the primary goal of why we're doing these operations? Well, we monitor our cancer results, and this is my institution versus the National Cancer Database reported in results between 2011 and 2016. And this is the survival rate by year, 1, 2, 3, up to 6 years after surgery. And the green bars are Virginia Mason, which is my institution, and the gray bars are national data. You can see that these pathways are making a major contribution to us having extremely good cancer results, in addition to being efficient with respect to our patients' immediate postoperative management. So what's the final word? Standardize your protocols and monitor your results. Unless you audit your results, your ERAS pathways will not be as successful as they could be. ERAS and standardized clinical pathways should not be static, they should evolve. You should identify where you're being successful and where you can be more successful, and make sure you change them over time. If you don't have your protocols embedded in order sets and considered standard work, there will be no consistency within your institution, especially if you have staff turnover. The patient and their families are your allies. Let them know what these goals are about and get them involved in achieving them in your institution. What's the final word? Should ERAS programs specifically adapted to the goals and resources of each institution routinely be used in centers doing esophageal resection? Well, my feeling is, in addition to doing the best operation we possibly can, the answer is an unequivocal yes. So I'm very pleased to be given this opportunity to speak today, and I understand there's an opportunity to ask some questions.
Yes, thank you very much, Dr. Lowe. Maybe, yeah, if you come back to us, that's perfect. Very impressive results in this talk. I can imagine there are quite a lot of questions. I don't know if everyone in the audience had the opportunity to answer on the polls. I see there's quite a lot of people who already answered, but there are more out there. So please fill in that your answers to the questions, and then maybe we can come back with some comments from Dr. Lowe on that. Let's have a look to the questions right now. Oh, this is already something completely different about training. I don't know if you can answer this question. How to train young surgeon doing esophageal anastomosis safely? Is there any installation?
And by the way, I have turned down my my speaker and my microphone as much as I can. I can certainly turn it down more if you think it would help. Is that better?
This is better, yes. I don't know if you should still disturb me right now, but
training the younger generation is constantly a challenge. What we have found is the aspect of ensuring that senior residents and fellows are involved in these operations at every level. Talented people will be able to be taught how to do an open and minimally invasive anastomosis in a standardized fashion. Much of what we do as surgeons, we can't do alone anyways, and it's a matter of apportioning these responsibilities. We have found that one of the biggest improvements we have made in teaching is our evolution into more robotic surgery. Utilizing the dual console and the simulator allows us to take techniques with our trainees from the preoperative situation and allow them to do components which can be switched back and forth. And this has definitely made the teaching aspect of things much more straightforward. However, if you were to ask me my opinion, doing a robotic anastomosis is one approach. You won't be able to do them all robotically, and therefore we should be teaching our trainees how to do anastomosis in these surgeries in every format.
Okay. And then a question I expected, I think. Do you feel minimal invasive surgery should be part of the ERAS protocol, or does the type of procedure change any finer points in the ERAS protocol?
There's absolutely no doubt that minimally invasive surgery should be a component of the delivery system. It's going to impact these outcomes even further. Most, not all, of the data I showed you today was with open surgery. I think that as surgeons, we have a responsibility to continue to evolve our art to decrease the impact to individual patients, and videoscopic, laparoscopic, and robotic surgery are a component of that particular issue. I will say what I said at the beginning of the presentation, however, is these evolutions are very important to us and they will impact outcomes. The aspect of pathways, however, are going to affect the results in your patients irrespective of the operative approach. So if you're doing fully minimally invasive or fully open, the aspect of utilizing these recovery infrastructural issues routinely are going to improve the results in both of those populations.
Okay. And then another very important question, I think, with such a short hospital stay, how do you manage anastomotic leakage?
Well, actually, I can tell you a funny story about this. That paper I showed you on accelerated recovery was presented at a major European meeting, and the surgeon got up at the end of the presentation, and it was not me presenting; it was one of our fellows, and he asked our fellow, he said, you know that if you do this, that a lot of your patients, they will die. They will die at home of anastomotic leaks. And the fellow actually handled this quite well. He said, well, sir, the anastomotic leak rate at Virginia Mason over the past 15 years is 4.3%. That's not inconsequential, and it should be a component of how you devise programs and how you protect your patients. There's two things that I think are important here. Do you develop systems for the 5% or do you develop systems for the 95%? In our scenario, you develop systems to make sure that the vast majority of your patients who are going to do well can do well. And the other thing that we've noticed is that when people are mobilized, when people are up and around, when people are further along in their recovery pathway, when they get leaks, they tolerate them better. Mike Griffin has said this multiple times. He and his group came to visit us 5 or 6 years ago, and it's not that the anastomotic leaks are not important outcome events. They're critically important. But the real issue is that they should not be the defining factor on how we deal with all our patients. We should do good operations, minimize anastomotic leak, and then devise systems which are appropriate for the vast majority of our patients, which in our case is 95% of our patients. In addition, when it comes to early discharge, we routinely follow people up through our cancer coordinators. So over the telephone, we're keeping in touch with these people, and they're given a very low threshold for recontacting us. I think that we all have to be concerned about the effect of leaks, but we also have to be concerned about our efficient protocols for overall recovery. That's a great question.
Okay, thank you. I would like to encourage the audience to ask some extra questions because Dr. Lowe is in the middle of his operation right now. So now is the moment, but maybe we can already comment on some of the polls we asked. Are you working in the first one? Are you working in a unit currently doing esophageal resections? Well, 88% of the audience is. I think that's quite logical with this theme. How many esophageal resections does your unit currently carry out each year? Most of the people watching are doing about in between 0 and 10, and then another third in between 10 and 50, and there's only a few people doing more. Can you comment on that? Is that important, the volume? Sorry.
Sure. There's no doubt that there's a great variety of the number of esophageal resections that are done in units who are that are interested in delivering this service. The reality is that the establishment of these protocols requires a certain amount of clinical volume. It's difficult for a unit that is doing 0, 1, or 2 resections every month or two to get to develop a system in which the whole staff, ICU nurses, ward nurses, dietitians, physical therapists, get used to managing these patients within protocol criteria routinely. That does not mean it can't happen. It can happen. But there is a greater challenge when your volume is not at a level where these patients are routinely coming through rather than occasionally coming through. This is why the move toward, in some cases, centralizing complex oncologic care makes sense. It's not that hospitals doing smaller volumes are not doing good surgery. Many of them are doing outstanding surgery. It's the aspect of putting together an infrastructure to support the patient globally, not just at the time of surgery, which makes this particularly important. I say this because the worst country in the world, the worst first world country in the world for centralizing cancer care is my country, the United States. So, and we have a lot to answer for that because, quite frankly, there are hundreds and hundreds of hospitals in the United States who do 1, 2, 3 resections a year. And once again, this is not a tenable situation in the long run. However, the truth is that if you get good protocols in place, and if your results are excellent, your volumes will increase.
Okay. Does your unit currently utilize ERAS in esophagectomy patients? This is about 1/3. So I think the rest knows how to start right now. Any comments?
I think that when you look at the ERAS publication that came out in February 2019, if you're looking to establish an ERAS program, you will feel overwhelmed if you think that you can produce or start all of those things at the same time. And I would encourage you not to do so. What you need to do is, I would hope, do a little bit of what I tried to present today. Identify what are the criteria within the ERAS pathway that you think are achievable for introduction in your unit at the present time. You can impact outcomes simply by, I think, introducing an early mobilization program or getting NG tubes out in day 2 or 3 rather than day 5 or 6. You can start with the components of what I presented today and impact your outcomes in the short term, and over time elicit the multidisciplinary help you'll need to introduce more and more elements within the ERAS pathway overall. So don't try to do everything at once, because you'll be, well, it will be a big challenge.
Okay, thank you. Do you find that ERAS has improved your esophagectomy outcomes? Well, there's almost 90% saying yes. A few are saying no, so this is also interesting. But yeah, the great majority is saying yes. And the last question was, what is the current mean length of hospital stay in esophagectomy patients at your hospital? And this is also interesting because it's quite divided. Most are in between 8 and 15 days, but 12% is saying in between 3 and 7. Very good. And then another 19% more than 15 days. Any comments on that?
Because I get the opportunity to travel a lot, I know that a lot of the aspects of how in-hospital stay is managed is not just on the basis of recovery, it's on the basis of cultural norms and other issues that are societal based and not medically based. The real issue is, however, is that I believe that medical resources in every country in the world are becoming a precious item. And one of the things that we can do to help with this particular situation is to ensure that we who are dealing with complex oncologic operations are as efficient as we can be with medical resources. I think in this day and age, with the right preparation, we should be routinely identifying that our patients after esophageal resection should go home between 5 and 10 days. I think that that's an achievable goal. It's a balanced utilization of resources. One of the most important things we discovered in the accelerated recovery group is that we thought that people would be unhappy because they felt that they'd been rushed out of hospital. At the time, and this is back in 2011, 2012, everything you read indicated that you needed to stay in hospital 2 weeks. And we were talking about patients leaving the hospital in 5 or 6 days. We found that it was exactly the opposite. When you highlighted to people how important it was to get up, move around, and to get out of hospital as soon as you could, and when you impressed not only the patient but their family with the importance of this, then they became completely committed to the goal with us. And that's why one of the final things I put on my slides is utilize the patient and especially their family as your allies. To give you an example, which I love to talk about, is that we tell people how important it is to get people up and moving on the day of surgery. So, and that's the day of their esophagectomy. And what we routinely find when we go around in the evening after an esophageal resection is the nurses in the ICU have been reminded by the family multiple times, well, you know, the team said that they were going to get dad out of bed and he hasn't got out of bed yet. And when you have that family dynamic working for you, then it actually improves the aspect of achieving some of these goals. And it keeps patient satisfaction at a very high level.
Mm-hmm. Yeah, very important. I need to tell this before your patient hospitalization.
I think that making sure that patients and their families understand what your goals are really a key issue, and that's why all of those things, even the ones we post in the room, we find very valuable.
Okay. Then we have some other questions. When do you routinely remove the feeding jejunostomy? And maybe I can add, when do you routinely remove the nasogastric tube?
The nasogastric tube, as we showed you in our protocol, we are now targeting for removal on day 2 or 3, and we're achieving that in 86% of our cases, and with a replacement rate that is almost negligible if we utilize the protocol using the upper GI.
Okay.
The feeding jejunostomy is a scenario which we usually utilize for between 6 and 12 weeks, and we do vary that on the basis of how the patient is doing nutritionally and how nutritionally stable they were throughout their neoadjuvant therapy and following their surgery. So we typically utilize the feeding jejunostomy flexibly. Virtually all of these tubes are removed by 12 weeks, but some of them are removed very early because people do well. The other aspect of the feeding jejunostomy is we're now putting about 40% of them in prior to their neoadjuvant therapy, because we're finding that people are presenting at nutritional risk, but also with significant levels of sarcopenia, which we believe can be helped with ensuring that they get their nutrition routinely, not just following their surgery, but throughout their neoadjuvant therapy. And we're currently looking at this data very specifically because we do believe that this is an interaction that's going to make a difference.
Okay. Then about the financial impact of ERAS, but we saw some slides about that.
you can make your hospital administrators very happy. One of the things that Sean Preston found when he went back to the University of Surrey is that he was able to get additional resources because he was able to show his administrators how much more efficient he could be with esophagectomy patients. So the appropriate application for ERAS pathways can be very beneficial across the board with respect to financial issues.
Okay. What day do you perform the esophagography to feel confident about the anastomosis? But it was not about for the anastomosis, it was more for the gastric emptying, you told us.
That's correct. You can't have gone to an esophageal meeting in the last decade without people highlighting the fact that they don't use upper GI contrast studies because it isn't accurate in demonstrating an esophageal leak. And we agree with that. I mean, when we do these studies, we obviously look at the anastomosis, but our goal is very specifically to assess our conduit emptying because it directs the next step in our pathway. It directs whether the NG tube comes out. If that conduit empties in the radiology suite, it's removed immediately on day 2. And then we proceed on with the advancement of what we call the oral protocol the next day. Just as importantly, however, if on day 2 it does not empty, then the NG tube is not removed, but we do start prokinetic agents. And then if the next day the conduit does not empty, then we endoscope the patients, dilate their pylorus, and inject Botox. So we have a protocol that will allow us to move along the pathway, but we also have a response if we find that the data that we're given at the Swallow study does not allow us to move along the pathway. And I think that that's equally important.
Okay. And then another question about the nutritional support. What is your target of oral intake when considering to stop the nutritional support of the feeding tube?
Sorry, what was the...
So at what time do you decide to take out the feeding tube or to lower the administration of enteral intake? At what point of per oral intake do you decide that?
The post-operative oral intake is a very prescribed aspects of a diet that the patient is given before surgery and then adheres to after surgery. The patient gets to what we would call a surgical soft diet, which is foods such as pasta and eggs and casseroles and softer foods within 2 weeks of surgery. We continue to limit the volume of what they can take in a single sitting to a cup at a time, as we believe that this has advantages regarding allowing the conduit to mature. Our goal, however, is as the oral intake increases, then the amount that we're using on the feeding tube decreases subsequently. This is why some people have their feeding tube removed at 4 to 6 weeks, whereas other people continue on their feeding tube for up to 12 weeks.
Is there a specific need of a percentage of estimated kilocalories they need, or?
All of these people are seen and monitored by dietitians, and the aspects of each individual dietary requirement is calculated on the basis of the individual patient and not a global approach. And as these people transition from enteric to oral intake, then they have periodic reviews, not personally with a dietitian, but over the phone.
Okay. Okay, perfect. Then someone who agrees with the family involvement, yes. Any other questions for Dr. Lowe? We're 5 minutes to 7, so this is actually perfect. If not, for me today, the ESTS webinar was great again with almost 50 attendees, a lot of interactions. On behalf of the ESTS Learning Affairs Committee, I would like to thank Dr. Lowe for this webinar today in the middle of his procedure. And you, of course, the audience, for your interest and interaction. I wish all of you a Merry Christmas next week and a Happy New Year. We will see you back on the 20th of January with Professor Jablonski from St. Petersburg about the surgical indications and techniques for TB. There's coming one more question. up. I see, do you routinely put a left side ICD? I'm not really. It's a costal drain. Depends a little bit. I think I let you answer this question.
Well, we have gone from 2 chest tubes to 1 chest tube. We typically put a single intercostal drain on whatever. We do right and left-sided resections depending on the presentation of the patient. And unless we have had a significant lung dissection, i.e. due to adhesions or something like that, we would place 1 posterior tube, which we actually have currently targeted for removing on postoperative day 3. We can do that because the patient is almost at tube feed goals, and the only reason to keep these tubes in the short term is to ensure that your chyle output is not significant before it comes out.
Mm-hmm. Perfect. So that's for the last question. Thanks again for this great presentation, and see you all back in 2020.
My pleasure. And by the way, I'll also wish everyone a very happy holiday and a Merry Christmas as well.
Thank you, Dr. Lowe.
Take care.
Bye.